theme of the conference being health research, I'm going to address the topic of desirable objects of observation for measuring person-centered medicine. We've just heard, and particularly African contributions in conceptual considerations of this topic. We've just heard about objects like particularly days of hospitalization and so on. And of course those are desirable objects in a certain way, but we may also consider them to be consequences of person-centered medicine. And of course those are desirable objects of measurement. But we could go also, and what my focus here is going to be, is on which objects are appropriate if we want to measure person-centered medicine itself instead of the consequences of utilizing those. So that's the link with the previous talks. What's clear to me is that we of course need measuring instruments to measure person-centered medicine everywhere in the world, and develop instruments, and there are of course some instruments appropriate. I'm going to consider some of those patterns in those. We need to distinguish in measuring instruments between the items or the criteria by which the various aspects of person-centeredness may be identified and evaluated, from the kinds of objects on which these items and criteria may be applied. If I may make this a bit more simple by looking at household contents. We need instruments to measure the quality of household contents. Then there would be items or criteria that would depict the quality, and then we need, of course, to think about on which objects shall we apply those measuring instruments, and that they would of course be like then chairs and tables and other kinds of furniture, crockery, cutlery, books, electronic devices. So the question is really about this second group. What kinds of objects are appropriate for person-centered medicine? Now, why this is so important? Well, the kinds of objects that you choose are really important to get it right for the instrument in terms of validity and reliability. This is quite obvious. I just put this quickly as background to be able to refer to it. Of course, to be valid, it has to be an appropriate object for person-centered medicine. I mean, if we start looking at clouds to see whether they are good household quality items, we would certainly find that they are not. So that would not be appropriate. And the others, of course, they should be representative. So it should be a representative kind of object. If we just look at chairs, that would not be representative of all household items. We may demonstrate good quality chairs, but that may not apply to everything in household items. Reliability, of course, that's about consistently identify the same object from person to person. And the more general the object, the less the consistency and the reliability. For example, if I want to evaluate the quality of household contents in general, then you may have chairs in mind and I may have tables in mind, and we may actually have bad inter-rate reliability because we've got different things in mind when we rate it. So in that sense, chairs would be better than furniture, and furniture would be better than household contents. Different levels of abstraction. So that's to take note of the embedded items and the consistency of embedded items and the implications for reliability. So the kinds of objects matter getting it right in terms of validity and reliability. So let's look at common things that have been used or maybe relatedly used in measuring person-centered medicine. Now, clinical consultations have been an object of observation, particularly in patient-centered medicine. And then it was about looking at patient evaluation, patient perceptions, patient satisfaction. So the object here for measurement was the clinical consultation, or more specifically, if you wish, you may say they were evaluations, or they were perceptions, or they were satisfaction. Now, of course, that says something of person-centeredness, because a patient is necessarily a person, so it is appropriate. Remember the appropriate this criterion for validity. So there's some validity, but the problem is that a person is not necessarily a patient. You may also, another way of saying it there is, there's a person behind the patient. So in that sense, it's not representative and thus lacking validity. Person-centeredness is more about patient-centeredness. So if I just may use the household content analogy again, quality of household contents, we can't get a representative, it has to be representative of household contents. We can't just look at chairs. By looking only at patients rather than persons, we've got this problem of looking only at chairs instead of all household contents. So it's not representative because person-centered medicine is not only about a person and his patient capacity, it's not only about patient evaluations, it's not only about patient perceptions or patient satisfaction. Another way of saying it, person-centered medicine is not merely a function of what a patient wants. And that's, of course, notwithstanding the fact that what a patient wants, and those things I've just mentioned there, are nonetheless important. So I'm not reducing the importance of it, I'm just saying that's not adequate. So, analogy again, I'm not saying chairs are not important when we consider household chairs, household goods, but it's not representative. Person-centered medicine is also not only about the patient, but also about spouses, families, the physician with specific values, medical values, legitimate medical values, and of course other professionals. So, and it's also not, person-centered medicine is also not only about clinical consultations, but it also, because person-centered medicine should also happen outside the consultation, in teamwork, service management, funders, considerations of funders and providers, in institutions, organizations, policies, regulations and laws, and you may continue with the list, where person-centered medicine should also happen. So clinical consultations as the object of observation is too narrow. Clinical consultations are also not representative because person-centered medicine is not only about clinical consultations. It's not only about patients and what patients want. That's, well, I'm summarizing what I've just said. So if an instrument merely assesses that, it's not representative and lacks validity as a person-centered measuring instrument. So another option, other than clinical consultations, would of course be to look at health systems as an object of observation. And the person-centered care index is doing precisely that. That's the one instrument that we have currently. But the problem with that is that health systems are farther removed from the person than consultations. Of course, consultations may also be a system, a microsystem, but quite often when we talk about systems, we talk about it at a more general level. So it's not clearly a person-centered choice to choose systems, because it's potentially too inclusive. If you'll pardon my analogy again, it's like using movable assets as your object of observation in measuring quality household contents. That would be too wide. So that again dilutes your validity. So, and if it's so general, it's difficult to attain the reliability. At the general level of specification, the embedded subsystems may vary considerably in the extent of their person-centeredness. And evaluators may easily mistake a subsystem as representative of the general case and hence then poor inter-rater reliability. Or you may get an average, which may be quite contradictory to a particular substance, or this average, how person-centered something is on average may have very little value. Unless, of course, one specifies the very this is not a problem if the subsystems are very similar to the systems. For example, in a computer system, your subsystems have to run fairly congruent before the macro system would produce. That's not the case in health systems, where we have varied levels of person-centeredness. So what else? Other than clinical consultations or health systems, what else may be objects? Well, one could look at policies, pieces of legislation, clinical cells, behaviors, actions, decisions, attitudes, processes, events, and of course all of those have can be potential objects for measuring person-centered medicine. And what I've done here is I've summarized what we've been saying so far in terms of consultations and health systems. We said, is a person key to consultation? Yes, necessarily. Health system, well, a person is not necessarily key to a health system consideration. Does it hold adequate scope for person-centered medicine? Well, in consultations, no. We've seen that many things happen outside consultations. Health systems may have that adequate scope. The problem of how general it is in terms of reliability, well, consultations got much less of that of a problem, whereas health system being rather general invoke the problem with reliability, and whether it allows for substantial contextual coherence and relevance. I haven't said much about that. So we can do the same now for policies, laws, and the other things that we've got here. So we may say policies is not, a person is not necessarily key to that, whereas behavior as a person is necessarily key to behavior. And we can do the same for the rest. I'm not going to overhear too much. And the same adequate scope, policies is inadequate to cover the scope of person-centered medicines, but clinical services may have sufficient scope. Or if you consider processes are of a nature that would be sufficiently covering the scope. And we can do the same for the rest. And what we want is, of course, I've marked the blue bit, so we won't actually go for the blue. If we have blue in all those categories, that would, of course, be the better object for measuring person-centered medicine. So now the African contribution is that of stories. And Indaba in isiZulu means a meeting or a matter story, or if I put that in a sentence, a meeting to discuss a matter where everyone has a voice and generate a common story to tell about the matter. Now, how are stories related to person-centeredness in African ways of doing? Batupele comes from the Sesotho word, which is one of the 11 official languages of South Africa, meaning people first, which prioritize the individual as well as the communal interest. And that's related to the concept of Ubuntu, which one can translate incompletely as being in existence with and through others. It's a way of living, thinking, and feeling an ordinary discourse about yourself and others. And this is expressed, Ubuntu is a sub-Saharan concept. More locally, this idea is expressed in isiZulu, one of the largest language groups in South Africa. About 20% of people speak isiZulu in South Africa. And that's translated, I am because you are, and you are because we are. You can see that interconnectedness. And this is really, so it champions both the person and society by virtue of interconnectedness. Now, where does stories come in? Where do stories come in? Stories are the shared connective of past and present person-centeredness. So if we apply that, so I'm adding right here at the bottom, story making. Is a person's key to story making necessarily? Does story making entail adequate scope for person-centered medicine? Yes. Problems of generality may be a problem there, perhaps, and it certainly allows for substantial contextual coherence and relevance. And story making entails actions, decisions, and decision-making events, processes of behaviors, and attitudes. The things we've got here on the left are entailed by stories. And of course, similarly, consultations may be considered as stories. Systems may be considered as stories in the same services and the like. So stories may be entailing. So story making as an object for measuring person-centered medicine, the validity contribution of that, well, persons and people are central in stories and story making as co-authors of it, as role players and voices, allowing for all the persons and role players. And all about persons in medicine can be accounted in stories and story making. It allows for substantial contextual coherence, and it's not restricted to consultations, patients' perceptions, or what the patient wants. The recorded story should be representative and co-authored. So what one needs to realize here, there's a difference between the story and the recording of the story. The recording of the story is another story. So the recording of a story is a story of the story. If I quickly This is now a recording going on here. So it records a story that goes on here, but that recording is a story of a story, because, for example, that lens does not include the screen behind, so it's not fully representative of the story. But if you want validity, of course, the recording should be representative. Reliability contribution. Well, stories also contain sub-stories and related stories. But which story to identify consistently from person to person is not usually the problem. The problem is usually with the recording of a story to get that representative. But you can guarantee that by making the recording of the story part of the story making, and of course to create co-authorship also by all the story makers. So my conclusion, in as much as stories would determine good validity and reliability of instruments that measure person-centered medicine, they are desirable objects for observation for the measurement of person-centered medicine. I thank you.